Good afternoon and welcome to our Neuroscience lecture series. I am Dr. Khaled Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Sarah Marmol. Her presentation is titled Update in the Treatment of Movement Disorders. Dr. Sarah Marmol is a neurologist at Baptist Health Miami Neuroscience Institute. She specializes in movement disorders such as Parkinson's disease, tremors, dystonia, and has specialized and special interest in clinical research. Dr. Marmol earned her medical degree at the University of Miami Miller School of Medicine. She also completed a neurology residency in movement disorders fellowship at the University of Miami Health System. Prior to joining Baptist Health, Dr. Marmol was a clinical instructor of neurology at the University of Miami Miller School of Medicine. Dr. Marmol is certified by the American Board of Psychiatry and Neurology. She is a member of the American Academy of Neurology and the International Parkinson and Movement Disorder Society. She has published numerous articles and research findings in peer-reviewed journals and presented scientific papers at professional symposiums nationally and internationally. Please, let's give a warm welcome to Dr. Sarah Marmol. Dr. Marmol, thank you so much for joining us today and for accepting our invitation. The floor is yours.
Thank you, Dr. Hakim, for that kind introduction. I'd like to thank the Baptist Health International team for inviting me to this lecture series. I'll go ahead and share my screen. Okay. So as mentioned, my lecture is titled Updates in the Treatment of Movement Disorders. I have no relevant conflicts of interest. And my objectives for the next few minutes will be to illustrate recent treatment developments, including FDA approvals in the following movement disorders: ataxia, cervical dystonia, Huntington's disease, Parkinson's disease, and essential tremor. I'll also be demonstrating classic phenomenology of these disorders through videos, and the goal is to develop an understanding of the role of these advancements in clinical practice. So there are several newly and soon to be available medications for patients with movement disorders. These may offer longer duration of effect with equal or fewer side effects than their predecessors, providing more options for our patients. Understanding the role of these treatments can, of course, improve patient care outcomes. So I'll show you this video of this gentleman. Bit of a delay. I'll give it a few seconds, if not, I'll skip ahead. Okay. So he's talking, but if you notice his head movements, they're regular jerky movements. So a type of tremor of sorts, but not a regular tremor. So this gentleman has cervical dystonia. So we're going to be talking about the FDA approval of daxibotulinumtoxinA for the treatment of cervical dystonia. So what is dystonia? It's a movement disorder characterized by sustained or intermittent muscle contractions, which cause abnormal, often repetitive movements, postures, or both of these. Dystonic movements are typically patterned, twisting, and may be tremulous, as in our patient. They can be often initiated or worsened by voluntary action and associated with overflow muscle activation, meaning neighboring muscle groups can come into play with the dystonia. So what is the role of botulinum toxin in dystonia treatment? So it's actually the treatment of choice for focal dystonia, such as cervical dystonia. And as you may recall, or we'll quickly review, botulinum toxin acts on the presynaptic terminal. So it prevents the vesicles from releasing acetylcholine, and that induces a flaccid paralysis. So prior botulinum toxin formulations, there's a few listed here. Patients experience a declining treatment effect at a mean of 9.5 weeks after injection and a mean time to symptom reemergence of approximately 10.5 weeks. So as you can imagine, the patients may experience benefit, but they have to come every 12 weeks for repeat injections. And it is an FDA-approved indication for the treatment of cervical dystonia. The following Botox, Dysport, Xeomin, and Myoblock, so all of them are approved. Level A has been given to abobotulinum toxin and remabotulinum toxin. So how is Daxxify different? It received FDA approval in 2023. The Aspen-1 trial, which we'll discuss briefly, showed that in moderate to severe idiopathic cervical dystonia, Daxxify reduces dystonia more effectively than placebo. It included adults aged 18 to 80 years of age with moderate to severe cervical dystonia, as measured by the Twister scale of a score at least at 20. These patients were enrolled at 60 sites across 9 countries in Europe and North America. So about 300 patients received randomized either 125 units, 250 units, or a placebo dose. The primary endpoint was a change in baseline in the Twister scale, the total score average across weeks 4 and 6. There was statistically significant improvement compared with placebo for both doses of Daxxify, so the 125 and the 250 units. And interestingly, you'll notice a slight kind of more improvement in the score, so lower being better, with 125 units compared to the 250 units. And both of these had a better improvement compared to placebo. So Daxxify, the mean duration of effect, defined as time from treatment until loss of 80% of the peak effect, again measured by the Twister score, was about 24 weeks with Daxxify 125 units and 20 weeks for 250 units. Again, a little unusual that the lower dose had a longer effect. So how does it work in comparison to the other modifications of botulinum toxin? So it's positively charged, which means it has an increased affinity for the neuronal membranes that enhances localization of the toxin at the presynaptic terminal, and that facilitates increased internalization of the botulinum toxin molecule. So it's more easily absorbed, and that's why the effect is longer. The most commonly reported treatment-related adverse events to be aware of: injection site pain, headache, and injection site erythema. Commonly reported treatment-related adverse events of interest were muscular weakness, musculoskeletal pain, and dysphagia. But these adverse events are actually typical of those reported in clinical trials of the other toxin formulations for cervical dystonia treatment. Okay, so we'll move on to our second topic. Give the video a few moments to load.
Your nose.
Okay, so we have a young woman with very irregular movements. It's hard to predict what exactly she's going to do next. You might describe this as kind of like a dance-like irregular movement. Persists with walking with different actions. So this is a young woman with Huntington's disease, chorea. We're going to discuss the FDA approval of valbenazine for chorea in Huntington's disease. So one of the motor features of Huntington's disease is chorea, but it can also include dystonia, gait and balance impairment, falls, rigidity, and bradykinesia. So chorea consists of involuntary, continual, abrupt, rapid, brief, unsustained, and irregular movements that flow randomly from one body part to another, as we just witnessed. Can be present in various bodily regions, including the face, the extremities, and even the trunk. Can affect time, fine and gross motor function, activities of daily living, gait, and balance. And as you can imagine, it affects the quality of life, leads to falls, can affect employment opportunities and independence of these patients. So valbenazine, or Ingrezza, received FDA approval in 2023 for chorea and HD. The Connect HD trial was a phase 3 randomized double-blind placebo-controlled study designed to evaluate the efficacy of valbenazine as a once-daily treatment. 128 patients were assigned to either placebo or valbenazine up to 80 milligrams is tolerated for 12 weeks of double-blinded treatment. So what is valbenazine? It's a vesicular monoamine transporter, or VMAT2 inhibitor, which basically makes it function as a dopamine depleter. So it prevents the dopamine, I guess, being reuptaken. It was previously approved for tardive dyskinesia. So in contrast to the other VMAT2 inhibitors, tetrabenazine and deutetrabenazine, it has the strongest affinity for VMAT2, as it is metabolized to only the alpha dihydrotetrabenazine stereoisomer. Valbenazine and its active metabolite have half-lives of 15 to 22 hours. So one advantage it has over these other formulations is it allows for once daily dosing as opposed to BID dosing. So in the trial, Connect HD trial, the primary efficacy endpoint was a change in United Huntington's Disease Rating Scale total from screening and baseline period, average of both of those assessments, to the maintenance period. So the average of week 10 and 12 assessments. A statistically significant reduction in chorea severity for valbenazine versus placebo was indicated by changes in the UHDRS total maximal chorea score, which was a greater change for valbenazine, a drop of 4.6 points, compared to placebo, only a drop in 1.4 points. Adverse events of valbenazine. So overall, the medication appeared to be well tolerated, with about 82% of participants treated with valbenazine taking 80 milligrams, so the highest possible dose at the end of treatment. The most commonly reported adverse events with valbenazine were somnolence, fatigue, and falls. However, the placebo group had a similar incidence of falls. Evening dosing can be used in patients who experience somnolence. 9 of the patients in the valbenazine group had a dose reduction because of adverse events, but as you can see, that's a minority of the subjects. No evidence of treatment-emergent suicidal behavior or worsening of suicidal ideation with valbenazine, and depression and anxiety scores remain stable. It's important to note that all Huntington's patients on VMAT2 inhibitors should be monitored regularly for suicidal ideation. All right, so we'll move on to our next topic. All right, so a young man, we're asking him to do some alternating movements of his hands, some clumsiness we can describe. We'll watch him walk a little bit, very uncoordinated. Some issues with his balance. So this young man has ataxia. So we'll discuss the FDA approval of omaveloxolone for Friedreich's ataxia. So what is Friedreich's ataxia? It's a progressive, autosomal recessive genetic neurodegenerative disorder, which affects approximately 5,000 patients in the US and 22,000 patients globally. In most patients, Friedreich's ataxia is caused by a biallelic trinucleotide repeat expansion, GAA, in the first intron of the frataxin gene. Normal alleles have fewer than 33 consecutive GAA repeats, whereas abnormal alleles carry 66 to up to 1,500 of these repeats. Clinical features, so ataxia, reflecting both proprioceptive loss and cerebellar disease, spasticity, increased tone, visual and hearing loss. Non-neurological features include cardiomyopathy, diabetes, and scoliosis. Most patients lose the ability to ambulate by their mid-20s, and unfortunately, average age at death is 37.5 years. So what is omaveloxolone, NRF2, and Friedreich's ataxia? So of note, over 15 clinical trials have failed to reach their primary endpoints in recent years for Friedreich's ataxia. They've looked at all sorts of targets, including the gene itself, precursors, cytoplasmic, mitochondrial. So omaveloxolone is a mitochondrial target. So the analogs are among the most potent activators of nuclear factor erythroid-2 related factor 2, or NRF2 for short. So in vitro, it's been shown to restore mitochondrial function in fibroblasts from Friedreich's ataxia patients and in neurons from multiple FA mouse models. So in February 2023, FDA approved Skyclarys, the trade name for omaveloxolone, for the treatment of Friedreich's ataxia in adults and adolescents aged 16 years and older. It's the first and only therapy approved for this indication. The primary endpoint of the trial, the MOXIe study, was a change from baseline to week 48 score on the modified Friedreich's ataxia rating scale, or mFARS. So we'll talk a little bit about this study. So patients were randomly assigned in a 1-to-1 ratio to receive either placebo or 150 milligrams per day of omaveloxolone. They were randomized to omaveloxolone. Those who were randomized received a mean decrease from baseline in the mFARS of 1.55 points at week 48. Those in the placebo group had an increase, however, so a worsening in the mFARS score of 0.85 points. And the difference between treatment groups was 2.4 points. Of note, there's a persistent benefit of the disease course. So they did a follow-up study, the MOXIe extension. So the difference in mFARS between the treatment and placebo group was preserved at the end of the delayed start period. So that's at week 144, or basically 2 years. So earlier treatment benefit and disease modification. Those who received the study drug during the placebo-controlled double-blind period experienced a sustained benefit, and this benefit could not be recovered by individuals who initially were randomized to the placebo group and then who were crossed over during the extension period, which implies the benefit of starting the medication treatment earlier. Patients in the treatment group continued to show slow disease progression, assessed by the mFARS, over more than 2.5 years of treatment in the extension. However, the cost of the drug may be prohibitive. It's $425,000 annually.
And I'll have you tap on him. And then your left hand.
So we're watching a gentleman doing some maneuvers. So let's pay attention to what his head and face are doing. He's having some kind of irregular movements there, which are involuntary and kind of worsen when he's doing these other things. So he's kind of distracted and the movements are a bit worse. So he has Parkinson's disease, and this was manifestation of his motor fluctuations as dyskinesias. So we'll talk about a few things that have been recently FDA approved, including IPX203, some infusions, phoscarbidopa, phospholipidopa, and apomorphine infusions, and also some updates in focus ultrasound and DBS advances. So of course, of note, April is Parkinson's Awareness Month. So just to be aware of that. And so Parkinson's disease and motor fluctuation. So early on in the disease course of Parkinson's, we should expect a smooth transition dose to dose of levodopa. As the disease progression, motor fluctuations begin to develop. So off time is defined as symptoms of PD that get worse before the next dose is due, so that the medication effect wears off, if you will. Dyskinesias or involuntary dance-like movements often, but not always, occurring at peak high medication levels. So IPX203 is formulated to provide immediate delivery of 25% of the levodopa dose, followed by an extended release portion of the remaining 75% of the levodopa. The ratio of carbidopa to levodopa is still 1:4, as it is in traditional immediate release formulations. However, the viability is greater if all its content is in immediate release form. So as compared to Rytary, which is another extended release formulation of carbidopa levodopa, both the immediate release and extended release beads contain carbidopa levodopa. So in this one, all of it is in immediate release form. There's also a sustained release polymer layer, which allows for slow release of the drug, a mucoadhesive polymer layer to keep the granules adhered to the area of absorption longer, and an outer enteric coating to prevent the granules from disintegrating too early in the stomach. So those are the two things. You have the immediate release granules and the extended release beads in the capsules. So in the trial, they found that mean off time was 4.5 hours following IPX203 treatments and 7.2 hours following immediate release levodopa and 5 hours following Rytary, which demonstrates a 2.7-hour advantage for this new medication over immediate release and about a 1-hour advantage over Rytary. And conversely, there was a corresponding increase in good on time, about 2.5 hours more than for immediate release, and again, about an hour more than for Rytary. So this is the RISE PD trial. It included about 400 men, 230 women, 500 patients were randomized. And again, least squares mean change in good on time. So interestingly, you'll notice that both groups got worse, but the immediate release, so the traditional Cinemet formulation, dropped by 1 hour of good on time, and the IPX203 only had a worsening of half an hour. So patients receiving IPX203 experienced a longer duration of good on time per dose of about 3.76 hours versus those receiving immediate release of only 2.2 hours. And the IPX203 treatment increased good on time per dose compared to immediate release, again, by 1.5 hours. And this was just approved in August of last year as Crexont is a trade name. So it's now available. Okay. So next we'll discuss about the new subcutaneous infusions that have been approved for Parkinson's fluctuations. So the first is phospholipidopa, phoscarbidopa, trade name BHIWeb. So the study was originally published in 2022. It just received FDA approval October of last year. And the other infusion is apomorphine. Trade name is Onapgo. It just received its FDA approval a few months ago. although the original study was published in 2018, the Toledo trial. So we'll talk about VIWeB first. It's the first subcutaneous infusion for levodopa-based therapy for treatment of severe motor fluctuations. It's a form of continuous device-aided therapy along the lines of DBS, the intestinal gel, and apomorphine infusion. And it may be an option for patients in whom oral treatment is inadequately controlling symptoms. So interestingly, it was approved earlier in Europe, January of last year, and there was a bit of a delay with the US FDA approval because of the pump itself, but not due to the medication. So patients who were included in the trial had an average of 2.5 hours of off time per day, and reduction in motor fluctuation was observed as early as 1 week of treatment and persisted through week 52, so over 1 year. The reduced off time was complemented by increase in good on time. The percentage of patients who experience morning akinesia, meaning kind of morning stiffness to the point where it's difficult for them to move at all, dropped from about 77% at baseline to 27% at week 52. Patients also had an improvement in sleep outcomes and overall improvement in health-related quality of life measures. The most common adverse events were infusion site reactions, followed by hallucinations and falls. Next, we'll discuss apomorphine, and afterwards we'll compare kind of the numbers of both. So apomorphine is a dopamine receptor agonist, which activates D2 slightly more than D1-like receptors, and lesser activation of D3 than other dopamine agonists, so different side effects. Delivered subcutaneously via continuous infusion or injection. It is lipophilic, meaning it crosses the blood-brain barrier easily. After subcutaneous injection, peak concentration is reached in about 10 minutes, and the maximum concentration of CSF is achieved after about 30 minutes. It may have an antidyskinetic effect as well. And while it was widely available in Europe earlier, there were several prior open label studies, again, a slight delay in approval in the US. So the main trial, the Toledo trial, the primary endpoint was an absolute change in off time from baseline to week 12. Secondary endpoints looked at response to therapy, patient global impression of change, a change in on time without troublesome dyskinesias, change in oral levodopa dose, motor scores in UPDRS part 3, and in the PD questionnaire, the quality of life scale. So comparing kind of head-to-head the two new infusions, the numbers are overall comparable and with a slight advantage here and there. So between baseline and week 12 within the study group, so an off time, VIWeB had a drop in 2.75 compared to 2.47 hours for ONAPGO. On time without troublesome dyskinesias, so an improvement in both groups, perhaps a slight advantage of the apomorphine infusion, 2.77 hours compared to 2.72 hours, and also an improvement in on time without any dyskinesias. So a slight improvement, a slight advantage perhaps of VIWeB 3.13 compared to 3.06 hours for apomorphine. The treatment difference between the placebo and the study groups. So both groups had an improvement in off time, and maybe a little bit higher for apomorphine, 1.89 hours compared to 1.8 hours for phospholevodopa. And both groups had an improvement in on time without troublesome dyskinesias. Again, almost 2 hours for apomorphine versus 1.7 hours for phospholevodopa. And both groups had an improvement in on time with dyskinesias, apomorphine closer to 2 hours and VIWeB closer to 1.8 hours. So in terms of adverse events, so there is a similar rate of dyskinesias in both groups. The phospholevodopa infusion had more infusion site events, such as erythema, pain, and cellulitis. However, apomorphine had a higher incidence of skin nodules, and rare, but there is a risk of necrosis. The phospholevodopa group had a higher incidence of hallucinations, 15% compared to 3.8% for apomorphine. The apomorphine group had a higher incidence of nausea, however, which is predominantly the most concerning symptom with apomorphine usage, in addition to somnolence and dizziness. And some patients with the VIWeB had a difficulty with the drug delivery system, but only about 5 out of the 141 participants. So overall adverse events, pretty similar in terms of rates, so 8 versus 9%. The ones for VIWeb were kind of more related to either cellulitis or general side effects, as you can imagine, dehydration, migraines, and again, kind of more of the hallucinations or psychosis in this group. And in the apomorphine group, hypotension, some hematologic and confusion, cellulitis again, and kind of more in terms of impulse control disorders or cognitive issues with the punding, episodic confusion, also some psychosis, but kind of comparable in both groups, and hallucinations. Some of these side effects were improved with dose reduction. However, punding, which is kind of when you start organizing things impulsively, did not improve with a change in dose. And there was no specified change in improvement with changing the medications for the hallucinations in the VIWeb group. And this is what the two pumps look like. So the VIWeb pump is a little bit larger compared to the apomorphine pump. So that might be another consideration for the patients as to how large they want their device to be. And as you can imagine, there are several agents actively in clinical trials for Parkinson's disease, about 100 in 136 trials, and that's as of January of last year, looking at both disease-modifying therapies and symptomatic therapies, so very promising time in the field of Parkinson's. Okay, and then lastly, we'll talk about advances in MR-guided focused ultrasound, or also known as high-frequency ultrasound or HIFU, and DBS for the treatment of essential tremors and Parkinson's. So MR-guided focused ultrasound, essential tremor. So in the US, it's been approved for staged, meaning you do one side first, then the other one, at least an interval of 9 months. And other tracks are being currently under investigation, but currently the VIM targeting the thalamus is the only one that's been approved. For Parkinson's, high-frequency ultrasound has been approved for only unilateral indications in the US. If they're tremor predominant, then VIM is again a viable target. But if they have advanced idiopathic PD or medication refractory with motor complications, the GPI is an option, globus pallidus interna. But again, only unilateral lesioning procedure. There are some trials for focused ultrasound in Parkinson's disease, but mostly in investigation. The main adverse effect of focused ultrasound in this population is ataxia, dysarthria, and balance issues, some of which are persistent, meaning over 6 months. All right. Bilateral VIM targeting in PD. So this is one trial where they kind of compared baseline to week 1 after the lesioning therapy. So they had an improvement in tremors by 96% and an improvement in disability of 92%. However, when they did the second side, it was 18 months later. Then they examined the person again 12 months after the second side. They had an 8% worsening in their tremor, and the disability was unchanged because they had persistent hemiparesis and ataxia. So the effect may fade with time because in Parkinson's, there's a higher likelihood of tremor recurrence. It might be because the disease itself is more progressive, irrespective of tremor suppression. Other factors may come into play, such as rigidity or the bradykinesia. And with the repeated procedure, there's a higher risk of side effects. So who is a candidate for HIFU or DBS and PD? So right now, the DBS for STN, GPI, those are approved indications. Currently under investigation is or kind of a viable option under certain conditions for the right patient is PD predominant unilateral symptoms or PD with treatment refractory tremor. But again, keep in mind that the disease can progress. So even if the tremor becomes under control, then you would have to monitor for the other cardinal symptoms of Parkinson's with the rigidity and bradykinesia that may come into play. Targets under investigation for Parkinson's. So again, bilateral DBS, GPI, and STN, thalamic VIM if they're tremor predominant, and experimental. So they're looking at STN bilateral ablation, and also the palatothalamic tract is under investigation with frequency ultrasound. And newly approved the past few months ago was adaptive DBS in PD. So we have had directional leads, a few samples here, meaning you can change the direction of the stimulation, or even kind of create what's called a virtual lead in between the two contacts on the electrode. So we can deliver stimulation where it needs to be, but now with closed loop or adaptive DBS, we can deliver stimulation when it needs, not when the patient needs it. So it uses local field potentials, or LFPs, which is an electric potential recorded in the extracellular space in brain tissue. So it's kind of similar to an EEG in that it records neuronal activity in a group of cells. But the advantage it has, of course, over a cortical recording like an EEG is that with the deep brain stimulation, the electrode is placed within the basal ganglia, so you can record activity directly from that site. So the software takes advantage of LFP in the beta range, meaning 13 to 30 hertz. So it records oscillatory power in the globus pallidus or the subthalamic nucleus, depending on the target where it's implanted. And it's used as a signal for adaptive DBS because it has a known relationship with fluctuating Parkinsonian symptoms, mainly rigidity and bradykinesia. It's known to be responsive to medication and DBS therapy, meaning that the signal can be suppressed with medication and with stimulation. And it's present in about 95%, so most patients in an off-medication state. So it's a fairly reliable signal to have. So if you think of deep brain stimulation as more of an inhibition of this over-organized oscillatory signals, the LFPs, when they're elevated, kind of signals that the patient is symptomatic. They're having more bradykinesia or more rigidity. So the software kind of learns what that signal is and learns to increase the stimulation at that time. If the patient is overstimulated, meaning they're being overtreated, the LFPs can drop. So that might manifest itself as either a dystonia or dyskinesia. So the software will learn that it has to decrease the stimulation at that point. So you're able, as a clinician, to set the parameters of the high threshold for stimulation and low threshold for stimulation based on the recordings. So the patient can go home on the recordings, and you kind of, when they go back to see you in the clinic, you see what happened in a typical day for them, see when they were high or when they were low, and kind of adjust accordingly, either the stimulation or the medications based on what you see. So the ADAPT-PD trial is the main trial for this approval. It was multi-center randomized crossover trial, looked at 40 STNs and 17 GPIs. The main outcome being a proportion of subjects with good on time, comparing adaptive DBS versus traditional continuous DBS. This was a non-inferiority trial. So they found that LFP signal was sufficient for adaptive programming, and that was present in about 84% of patients, regardless of their clinical subtype, and with similar detection rates between STN and GPI targets. The medication had a relatively small impact on LFP detection rates, about 6% higher detection rate off medication, which means the detection of the signal may be sufficient for adaptive programming in a large majority of patients without necessitating medication withdrawal, which, as you can imagine, if patients are more advanced, necessitating a DBS, taking them off medications even for a short period for programming can be very uncomfortable. So we can kind of spare them that with this new system. All right, so lastly, things to keep in mind. So who can you offer these two HIFU or DBS to? A few things to keep in mind. So are they able to tolerate a stereotactic procedure to begin with? Would they benefit more from a lesional procedure like the HIFU or from stimulation? So you'll have to look at their clinical features. Are they tremor dominant? Is their disease mostly unilateral? Is there a risk of progression? Do they have medication side effects like dyskinesias? How would they feel about having an implant and their overall age? Then you have to decide whether they can be okay with a unilateral or bilateral procedure. And then you look at their risk profile. So if they have significant brain atrophy, there's a high risk of brain bleeding with deep brain stimulation. If they have other comorbidities that would preclude them for a more invasive procedure like DBS. Cognition, so there are some reports of worsening cognition with deep brain stimulation, so that'd be one thing that might exclude them from that. And of course, their age again. Skull density, so in order for them to qualify for high frequency ultrasound, do they have to have a certain skull density? Otherwise, the focused ultrasound rays won't be effective. Are they distant from the programming center? So there are DBS manufacturers where you can do remote programming. When the initial period, it's better for them to have closer follow-up to kind of optimize their settings. So that'd be one thing for them to keep in mind. Patient preference. So with the high frequency ultrasound, it would necessitate them shaving their whole head. So some patients might not find that too appealing. Would they want to be living with the implant? So it kind of looks like the pacemaker battery. So would they be okay with walking around with one of those? Would they be able to tolerate an awake procedure? So high frequency ultrasound is an awake procedure. DBS can be done awake or under sedation. And again, the availability, is it somewhere that's close to them? Are they able to afford it? And will insurance cover it? Okay. So in conclusion, to summarize, there are several newly and soon to be available options for patients with movement disorders. So we talked about cervical dystonia, doxybotulinum toxin, which provides longer duration of results up to 24 weeks. We discussed Huntington's chorea, valbenazine, which provides once daily dosing without the need for titration. We discussed ovalloxolone, which is now approved for Friedreich's ataxia and appeared to slow disease progression. We discussed bilateral HIFU VIM targeting for essential tremor. And for Parkinson's, we discussed IPX203, or trade name Crexont, which improved good on time versus immediate release carbidopa-levodopa. We discussed the two subcutaneous infusions, phospholevodopa, phoscarbidopa, and apomorphine, and both of which reduced off time and improved good on time. We talked about unilateral HIFU, now approved for GPI and VIM targets in certain patients with Parkinson's disease. And lastly, adaptive DBS, which is now available for patients with this. All right, I'd like to thank you all for your time and attention, and I'd be happy to take any questions.
Thank you so much, Dr. Marmol. I mean, this is a mind-boggling amount of information that you have compiled. It is amazing what neurology has accomplished in the past 10 years with the advent of the new technologies, as well as the new medications that you have at hand to help. But I loved your last the last slide before the conclusion, where you talked about which procedure for which patient, because
Right.
that is perhaps one of the biggest conundrums internal medicine physicians have, or PCPs, when they encounter a patient with a movement disorder. We don't know exactly how to guide and route that patient. And of course, we become referrologists. We become the ones to refer to you or to the movement disorder center for you guys to understand exactly what direction to take. Now, it is important to mention that nowadays, obviously, the new technologies such as the DBS and HIFU and all these other incredible technologies, the TMS and so on, are beginning to be known in our sector, in our industry. Therefore, a lot of the patients already come with perhaps a misconception that, look, I heard about HIFU, I suffer from dystonia, can that be applied to me? Would I qualify? So how do you make that initial distinction? How does your department assess the need of a specific treatment? Because obviously nowadays people are more cognizant that there is help out there, that it is not necessary for a Parkinson patient to sit, or a chorea patient to sit and just wait for longevity to take him. So can you just go a little bit more into that direction so we could all understand how to help guide those patients to you?
Sure. Yeah. So kind of a good example is the Parkinson's patient. So not infrequently people come kind of interested in the high frequency ultrasound because it's one of the newer things on the market. But it's important to be aware that kind of the way I counsel them is there's risks and benefits with everything. So as appealing as it might sound, it's still at the end of the day a type of procedure. So as long as they understand that the risks of it being with the high frequency ultrasound, a permanent lesion, I compare that to what the advantages are versus DBS. DBS has the advantage of being modifiable. High frequency ultrasound has a benefit of it not being kind of an invasive procedure,
Right.
but both have risks of their own side effects. So first I counsel them on that. Then I kind of work on where they're at in terms of the medication regimen. If there's room to optimize a conservative approach, that's what I do first. And of course, their input is weighed in. So if they're tired of being on so many medications, that's of course something to kind of factor in. If they're having side effects from the medications, then they're kind of being pushed more towards the advanced therapies. But now we don't have to jump straight to the, I guess, the more surgical approaches. We have the in-between, what we can think of, the subcutaneous infusions. So there's kind of steps of escalating their care. And I kind of present it that way. So you don't have to kind of jump from one thing to another, or you're not necessarily being excluded from the surgical or the high frequency ultrasound, but there's kind of room to work with in between. So there's different options. So I always present them with the options.
So is it typical, the same for other patients? You presented different conditions such as dystonia and Huntington's chorea and so on and so forth. Obviously, you need to get to the base and understand exactly what the diagnosis is in order for you to go one way or another. But does it work in the same fashion? Neurology has always been somewhat of a mystery for internal medicine and primary care physicians. So does it work in the same fashion?
Pretty similar. Yeah.
Yeah.
So first is, of course, like you're saying, confirm the diagnosis, whatever workup might be necessary, kind of imaging, what have you. So like for example, so for the Botox, a lot of people are hesitant to have a needle kind of in
Yeah.
their neck muscles, understandable. So there are medication options to try that. So again, kind of conservative and slow if they want. If some people are very on board with the Botox and they want to do that right away. So it's very patient dependent.
So I recall you mentioning during your presentation that in dystonia, for instance, in the use of Botox, you have to use it, I think, every 12 weeks. The patient has to be in a 12-week period. Can you go over that briefly in regards to perhaps the detrimental effect, if there is any, for a long period of time? And when do you actually switch gear to start other ways of actually treating dystonia?
So I guess in terms of the timeline of when a person is injected, so they start to notice the effect 7 to 10 days. Yeah, peaks at effect about 6 weeks, and it wears off by 12 weeks with the other formulations. So Daxxify, actually, that's the one I kind of have been preferring with the international patients because they do have travel, restrictions. So that one they have to come in every 6 months. So only twice a year they have to make the trip here. With either type of formulation or any of the formulations, normally about 3 injections is what it takes to kind of optimize it. So that's the other way I constantly limit. It's not going to be the first injection where we kind of hit the bullseye. It does happen, but it's not always. So
Right.
it takes patients patients from, I guess, the clinician and also the patient themselves. So we both have to be on the same page about it not being kind of like a one and done. We're going to have to work together to kind of optimize the treatment for them.
Right. And the injection goes straight to what area?
Yeah, so we kind of target it based on what we see them doing. So if I see they have a tremor that's kind of like yes, no, or
Yeah.
like this, like head shaking, then I target the muscles that control those 2 movements. So it would be from
Okay.
if I see them go
So
like this, it would be like this different set of muscles.
So traditionally, where Botox really work, which is to paralyze that particular muscle that is
In the
involved
muscle groups.
in
That's right.
in the group. Okay, great. And then you spoke about the other one, which is I don't recall exactly the statistics, but in the case of Korea, that you have to use these very in ataxia, the very costly medications versus the one you use for Korea. How do we place these patients that require these medications? Can we get them here in the States and they can take it with them? How do they actually manage for them to continue this internationally?
That's actually not too sure on the logistics behind that. Most of these companies with their newer drugs, they do have patient assistance programs. But as far as the logistics with the international patients, I would have to look more into that.
I will share some light on that, but I was more, I will share how it works. But in the case of these medications that are new,
Yeah.
is there a difficulty in actually managing those medications by the patient abroad, or do we need another provider to help you manage these patients as they are convalescing or seeing improvements and so on?
Yeah. So yeah, ideally we would work with a neurologist who's closer to them should they have side
Okay.
effects. That would be the best.
Okay, and let me share some light, shed some light in regards to how we work. So let's assume that you have a patient, an international patient that we brought to your office, and you diagnose them, in this case, with ataxia, for instance. And it's a very expensive medication. Obviously, they might not have it in their country.
Mhm.
What we do at International is you call us and you let us know that you have this patient, and we need to place this patient in continuation of care in the treatment plan that you selected, and we will actually manage in finding that medication for the patient and position the medication with the physician out in the patient's home country. And that way, through Zoom, you and the doctor can communicate and explain to him or her what the treatment plan is and how to monitor, and then you can subsequently have meetings through Zoom, through international. But that is a separate group of conversations that we can have. But I was just wondering how we would do with these medications that are recently approved or still under investigation. One more question, Doc, and it has to do with gene therapy. We have heard a lot of great things, talking about gene therapy and CRISP and all this crazy stuff, especially for Parkinson and gene therapy. What are your sentiments? What have you heard? What are you looking for in the future with this medication, with these technologies?
Yeah, so it's a promising time. There's a lot of trials, like you're saying, kind of focusing on certain, I guess, pathways, certain proteins, kinases, what have you. But I guess the important thing is you would first have to have the gene first to be a target or candidate for that target. So for example, something like Parkinson's, it's actually the minority of patients. That's one common misconception a lot of patients have. So only about 10 to 15% of cases are actually found to have a sort of culprit gene, if you will. So as promising as it is, it still will only be available for a minority of patients, but the trials that are ongoing, kind of phase 2, phase 3, so far sound promising. And each, again, carry the risk of their own adverse events, but overall, it seems like there are some promising things in the pipeline.
That's wonderful. I wonder what would happen in 5 years when we have, again, a conversation on this. That's wonderful. Look, I know that we can keep you forever because it is a conglomerate of different topics here intermixed, and they all sound the same to some people, but it is very distinct, and the treatment plans are so far in between sometimes. Dr. Gassan is asking if those medications are just for control the symptoms or with the intent to cure. Are those medications for controlling symptoms or just to cure, or the intent to cure?
Yeah, so I think of the ones I discussed, the only one that was kind of disease modifying was the omaveloxolone. But all the other ones for Parkinson's, for chorea, those are all just symptomatic treatments.
I see. Well, Dr. Marmol, we are thrilled to have you in our team. Welcome once again to Baptist. I know that you have a wonderful career with us, and we are expecting much more out of Movement Disorder Center. And I know you're also very excited about the prospect of bringing new technologies on board. And on behalf of our entire team at International, thank you once again for this amazing presentation. And to all of you and the audience for listening to us and once again attending to these great webinars. If you have any additional questions for Dr. Marmol, please make sure to send them to BHIWebinars@baptisthealth.net as it's laid in your screen, or just email us with any of your concerns regarding your patients, and we will make sure to send them to Dr. Marmol for her to have a quick look and an assessment. We look forward to seeing you all again at our next Neuroscience lecture series. This time is scheduled for July 23rd, 2025. Thank you once again. Have a great afternoon. Thank you, Dr. Marmol.
Thanks.